Welcome, everybody. Thank you very much for joining us today. My name's Rasha Alami, and I'm from Imperial College London. And I'm here today with some fantastic colleagues to discuss whether PCI outcomes could potentially get any better. And in particular, we're going to be focusing on whether we can advance the standard of care with Bioadaptor. So today I'm joined by David Erlingi from Sweden, by Johan Bennett from Sweden, from Davide Capodano from Italy, and Teguh Santoso from Indonesia. And it's my absolute pleasure to host this webinar today. But importantly, we'd like to highlight for all of you that this is a webinar for education. And if you can, put your questions in the chat, try and make this as interactive as possible. We're all here to answer your questions and hopefully to have a lively discussion. And my colleague Davide Capodano will be leading the discussion at the end. So in terms of our course agenda, we're going to go through some of the data that we have here, the latest clinical evidence from INFINITY-SWEDEHEART RCT and the Bioadaptor RCT, and David and Johan will lead us through that data. We're then going to have a discussion, and Davide will talk to us about the clinical implications and lessons that we've learned from the data, and in particular, the randomized control trials. But of course, this is very much your opportunity to ask questions. And then we will hear from Professor Santoso, who will give us some case presentations because he really has a lot of experience in using the bioadaptive technology in his PCI and his clinical practice. And then finally, we'll obviously go ahead to wrap up, but hopefully by that stage, we hope that we'll have answered many of your questions. So let's look at some of our objectives today. So the primary goal of this webinar is really to look at the unmet clinical needs that we have at the moment in terms of coronary angioplasty, but in particular for the current drug-eluting stent platforms that we have. We're going to review some of the clinical evidence around the DynamX Bioadaptor platform, and that in particular the data from INFINITY-SWEDEHEART and from the Bioadaptor RCT study. And we'll also discuss the implications of all of this data on our daily clinical practice. So let's think first about the unmet clinical need. I guess we've started to think more recently that the drug-eluting stent technology has got better and better and the outcomes have genuinely improved. But actually what we need to remember is that for some time we've seen that there is a considerable event rate that persists after PCI of around 2 to 3% annual event rate with ongoing long-term complications for our patients. And importantly, what we see is higher than expected target lesion failure rates with the contemporary drug-eluting stents. And you can see here that those rates are really consistent across all of the drug-eluting stent platforms. And so while things have improved, they certainly aren't yet at the place where we would say they're absolutely ideal. There's still potentially some place for a benefit. And I guess what's been a kind of promise for all of us is the promise of potentially having technologies that leave nothing behind. And we've known that metallic platforms, perhaps in the long term, still have their complications. We hoped that the bioresorbable scaffold technology and also that the newer drug-coated balloons technologies would help us to improve outcomes. Maybe if we don't leave any metal behind, we get better outcomes for our patients. Unfortunately, that's not what we've seen from the data. We all know the story for the bioresorbable scaffolds. We of course, don't really use them in our clinical practice now. There are some newer technologies with some potential promise. And of course, from the DCB space, there are people who are very evangelical about the DCBs, are using them all the time in their clinical practice. And there's others of us who are perhaps a little bit more conservative on our approach and still feel that we need to wait for more data. So what about new platforms? What could we potentially think about in terms of promise? So one of the issues around vascular biology is that with the platforms that we've had, there's been an inability to restore vessel function. And maybe if we don't restore vessel function after coronary angioplasty, we have higher adverse event rates. And this is really the hypothesis that drives this newer technology. And perhaps it's important for our patients to improve their hemodynamics. And if we don't improve their hemodynamics and restore vascular hemodynamic function, then we have a problem in terms of long-term outcomes. It's important to remember that normal vascular biology plays a key role in terms of regulating vascular tone and in terms of adaptive remodeling for the artery. And that's very important in terms of determining healthy and diseased arteries and what happens next. What we also know is that compliance and the loss of compliance and pulsatility within a vessel may lead to worse long-term outcomes and perhaps lead to worse atherosclerosis. So this is where the newer technology comes in. And what we have now is bioadaptive angioplasty, which has the promise of restoring vessel function. And with the DynamX Bioadaptor platform, we have a new novel technology. And it's pertained to restore vessel function. And maybe with restoration of vessel function post-angioplasty, it might address some of the device-related adverse events that we've seen from other technologies. So at this point, I'd like to hand over to David Erlingi, who's going to talk to us about some of the data and see whether some of that promise and some of those hypotheses are now starting to play out into our clinical data. David, it's over to you.
Thank you, Rasha. So it's a pleasure to tell you about the INFINITY-SWEDEHEART randomized clinical trial and the one-year outcomes. And I'm from Lund University in Sweden. This is a mechanism of action picture, and the first 6 months and during implantation, the bioadapter or DynamX behaves like top-of-the-class drug-eluting stents that we have today. It's easy to deliver, and it establishes a good lumen with very little remaining diameter stenosis. But after 6 months, then the interesting thing happens. There are links along longitudinally along the bioadapter that are held together with a polymer. But when the polymer is absorbed, then the links can unlock and the whole bioadapter can uncage. This allows for maintenance of flow lumen by positive remodeling, and it also restores hemodynamic modulation. So it can restore pulsatility, compliance, coronary flow, vasodilatations. And these are, of course, very important for vessel function. In short, the bioadapter restores physiology of the coronary artery. And this has been shown in the bioadapter mechanism of action cohort, where during implantation, the remaining diameter stenosis is similar to that of Onyx, one of the better drug-eluting stents, especially during implantation. But at 6 months, it maintains flow lumen to a greater extent than the Onyx stent does. And also it restores pulsatility and adaptive coronary flow volume. It restores hemodynamic modulation. So the objectives of our RCT was to establish the safety and efficacy of the DynamX Bioadapter in a large multicenter RCT in a broad patient population that represent daily clinical practice, including a lot of acute coronary syndromes. And we also wanted to look at the mechanism by doing a landmark analysis from 6 months to 12 months. So we included 2,400 patients, which is a rather large PCI study, in 20 sites in Sweden. We randomized them 1-to-1 to DynamX or Onyx, and we had a primary endpoint of TLF at 1 year for non-inferiority, but also powered secondary endpoints for landmark from 6 months to follow up for TLF and TVF. We wanted to have an all-comer population, so we restricted the use of inclusion-exclusion criteria. Patients could be more than 85 years, they could have stable coronary disease, they could have acute coronary syndromes, and so on. There are some exceptions with short life expectancy, of course, and some angiographic criteria, left main, bypass graft, restenosis, CTOs, and osteostenosis, but very broad inclusion. And the demographic was similar in the groups, indicating good randomization and similar to other clinical trials, except that we had a lot of acute coronary syndromes, 77% in the DynamX group. We had a lot of STEMI, 23%, and then we had 23% of CCS. The procedural success was excellent, and the device success excellent, both of them around 100% for both DynamX and Onyx. So it's very good during implantation. So here's the primary endpoint, the non-inferiority limit for target lesion failure at 12 months. And here we can see that the endpoint was met with a p-value of less than 0.001. I think we could add 10 there, actually. But it was very clearly met with 2.35% for DynamX and 2.77% for drug-eluting stent. And of course, non-inferiority is important. It established safety for a new device and so on. But it's not good enough. We are more interested in superiority endpoints. But you can see the different parts of the TLF component, and you can see that the numerical reduction at 12 months for the whole period was driven by target vessel MI and ischemia-driven TLR. And there were very low stent thrombosis in both groups. TVF looks similar, a numerical reduction over the whole period with target vessel MI and ischemia-driven TVR as drivers. So more interesting is the powered secondary endpoint landmark analysis. We knew that the bioadapter will behave exactly like a drug-eluting stent the first 6 months. So we expected exactly the same or similar results during that period. And we also knew that that would pollute or dilute our results for the whole period. So therefore, this was pre-specified and powered to see between 6 months when the bioadapter has unlocked and further on what's happening with the endpoints. And here we get the really interesting results. For the TLF events, there is a clear reduction with a p-value of 0.003 in favor of the bioadapter. And you can see how the event rate has plateaued here at 6 months. Actually, it's only 2 events out of 1,200 patients that happens during this period. At the same time, you can see the Onyx is continuing to accrue events, as we know from all the drug-eluting stent studies that has been done the last 10, 15 years. So event rate continue in the Onyx, but they plateau and do not continue to increase for the DynamX. And if you look at the different parts of the TLF endpoint, you can see that it's TVMI and ischemia-driven TLR that are the drivers, and actually both of them are significant by their own value at between 6 and 12 months. And then the TVF looks very, very similar. It's very significant, 0.008. And again, you can see the plateauing of event rates for the DynamX. So in conclusion, in this large RCT enrolling a broad clinically complex patient population with a large proportion of ACS, the primary endpoint was, or non-inferiority was met with a very strong p-value. And in the really most interesting pre-specified landmark analysis, there was a significant reduction in TLF and TVF, very strongly significant after 6 months for superiority. And so the INFINITY-SWEDEHEART trial is the largest RCT to confirm consistency of low and plateauing adverse event rates versus drug-eluting stents after the unlocking of the bioadapter at 6 months. And it confirms the novel impact of the bioadapter in CAD treatment by restoring the hemodynamic modulation of the diseased artery.
Thank you so much for that, David. That was fantastic. And now we move on to Johan, who will talk to us about the next big piece of data that we'd like to discuss today, and that's the 2-year outcomes from bioadapter RCT.
Well, good afternoon. It's a real pleasure to present the two-year data from the Bioadaptor RCT. This was presented by Professor Saito as a late-breaking trial at EuroPCR earlier on this year. So in this very short presentation, I'll report the two-year outcomes of the Bioadaptor RCT and also try and link these results to the significant one-year imaging outcomes which demonstrated restoration of hemodynamic modulation. Briefly, the Bioadaptor RCT was a single-blind randomized control trial performed in 34 centers across Germany, Belgium, New Zealand, and Japan. 445 patients were randomized to either the Bioadaptor or the Resolute Onyx. Primary endpoint was target lesion failure at 1 year, powered for non-inferiority and an intention to treat analysis. There were a number of secondary endpoints, including QCA, but also intravascular imaging analysis. And today we'll look more closely at the 2-year clinical follow-up results, both as an intention to treat analysis, but also the per protocol population, as a number of patients, 3 had a protocol violation and 2 patients had a randomization error. So the baseline patients were very similar in terms of their characteristics. You can appreciate, I'm sure, that the LAD was the most frequently treated vessel. Patients also had osteal lesions, bifurcation lesions, moderate to severe calcification was also present. And you can appreciate just above 20% of patients had an ACC, AHA lesion B2 or C. The primary endpoint of target lesion failure at 1 year was met with a TLF rate of 1.8% in the DynamX group compared to 2.8% in the Onyx group, with a p-value less than 0.001 for non-inferiority. This slide you've seen before, I think, by Professor Erling a few minutes ago, but just to show you in terms of QSA analysis, flow lumen was established with an acute stent-like result, as you would expect. At 1 year QC analysis, there was significant or lower diameter stenosis in the Bioadaptor group. And there was restoration of hemodynamic modulation at 1 year in the IVUS sub-analysis sub-study. There was restored pulsatility and adaptive flow, as you can appreciate here, with a significant increase in lumen area and coronary flow throughout the cardiac cycle in the Bioadaptor group as compared to the Onyx group. An unexpected but very interesting finding was the volume, the plaque volume present at 1 year follow-up. In all lesions, the plaque volume, which is the volume of plaque behind the stented segment, remained very stable in the DynamX group, as you see here on the left-hand side, whilst in the Onyx group, as expected, you would get an increase in plaque volume. Looking at the lipid-containing lesions only, there was actually a significant reduction in plaque volume behind the stented segment in the DynamX group, which was very significant compared to the, as expected, plaque increase in the Onyx group. Looking then at the 2-year event rates, we can see here that this was 2.3% in terms of TLF rates at 2 years for the DynamX compared to 5.5% for the Onyx. You can appreciate here also from 1 year onwards, so from 360 days onwards, that there was really flattening in the Bioadaptor arm, whilst the curves continue to separate with increasing numbers in the Onyx arm. By looking at the per protocol population, we can see again a significant reduction in TLF rates of 65% with a p-value of 0.046 for superiority. And this reduction in event rates was driven by lower cardiovascular death, lower events of target vessel MI, or clinically driven TLR rates. When looking at lesions which are at higher risk of restenosis, such as the LAD due to torsion, motion there, small vessels, bifurcations, long lesions, we can see here specifically in the LAD a significant reduction in TLF rates at 2 years, with only a rate of 1.9% in the Bioadaptor group compared to the 8.7% in the Onyx group. Numerically, there were no events in the small vessel or long lesion group. And finally, looking at the target vessel failure rates at 2 years, again, we see here a significant reduction in these rates in the group of patients treated with the DynamX, with a p-value of 0.029 for superiority. So if I may conclude, the 2-year follow-up results of the Bioadaptor RCT have shown a significant reduction of 65% in TLF rates, with further separation of the Kaplan-Meier curves and flattening between 1 and 2 years for the Bioadaptor, with only one case of TLR occurring between year 1 and 2. Lesions at high risk of restenosis, the LAD again had a significant reduction in TLF of a rate of only 1.9%. So the DynamX Bioadaptor is perhaps the first technology with a novel design and mechanism of action that seems to restore hemodynamic modulation to the artery and thereby deliver a sustained significant clinical benefit, perhaps establishing a new therapy and potentially a new standard of treatment for patients with coronary artery disease. Thank you very much.
Thank you very much. That was fantastic, Johan. Great. So now it's over to Davide to talk about the clinical implications and to really lead us into a discussion about what the data might mean now for our clinical practice.
Okay, thank you, Rasha. Congratulations to David and Mathieu, of course, who were among the leaders of these trials. Maybe I can really start to frame the topic before the discussion with some key messages and lessons that we have learned from the experience with the two studies. I think the important story here is the consistency, I would say, because taken in isolation, both studies may be seen as nice episodes, telling good stories, of course, for our patients. But what strikes me is really the shape of the cumulative incidence curve, which is somehow consistent in the two studies. So 2 episodes make a story, as I like to say. And in this case, what we have learned is that the event rates are low. They plateau with this bioadaptor versus standard reference comparator, which is one of the best-in-class drug-eluting stents. And this is particularly seen after 6 months, which is the time point where we expect the unlocking that you explained, Rasha, at the beginning to happen. The second point is that the mechanism of this benefit in terms of clinical impact, of course, seems to be in the story of hemodynamic modulation of the diseased artery, and probably I will ask something more to David in that respect. I think now we can say that when a new device enters the arena, let's say there are many options, of course, for treating coronary artery disease. Well, we need evidence, we need data. And now there is evidence because we are talking of 2 studies. One is smaller and another one is large scale. And so what we see is that this new concept, maybe one day new paradigm, the so-called bioadaptive angioplasty, it's a promising option for patients to improve the outcomes at the very long term and try to address that problem of continuing accrual of events every year, especially after the acute phase after the index procedure. So in a way, we are in that field of leave nothing behind strategies with a concept which is not a drug-eluting stent, it's not a bioresorbable scaffold, it's not a drug-coated balloon. And another point I want to remark, and maybe also another question, is about how much this population is eventually representative of the typical patients we see in our cath lab daily practice. We have seen that these participants also had in some proportion ACS lesions that were B2 or C according to the usual classification of the AHA-ACC. There were also long lesions as small vessels, so I'm curious to know how these results apply to most complex setting. So now I would like also to bring in the 2 speakers for some questions. The online chat is open and I see already many questions. And of course, I would like to give priority to the questions and concerns that come from the online audience. And maybe my first question is one methodological in a way that I would ask to David, because one of our viewers is asking about this practice of randomize within a framework of a registry. So maybe it's a chance to clarify, because they ask whether this is prospective, retrospective, how it works in practice. Of course, we know your registry has run many randomized trials, but can you briefly explain how it works?
Yes, so in Sweden we have our quality registers, and we also have the usual governmental registers and personal numbers, which means that we can follow the patients forever without losing or none of the patients, at least not for mortality. So that is a great advantage. So we did a kind of a fusion of just using the registers as a register-based randomized clinical trial, and also adding on the traditional RCT, like blinded CEC and DMSO and safety committee and so on. And we also had phone interviews. But the register gives us the opportunity to find the patients easier and randomize within the registers. So you just click on you open the register anyway, and it tells you that this is a patient that could go into the INFINITY trial, and you click, the patient says yes, the patient fulfills inclusion and exclusion criteria, and then you randomize. So extremely simple. And then we can use the registers to follow the patient. So we have a double mechanism to find events. We both call the patient and talk to them, and we also screen the register.
Okay, thanks so much. So prospective, randomized, no doubt. One question now that comes from Michele Cocciani from PISA, and that's, I think, a very legitimate question, because what he discusses is that these studies are always non-inferiority. You compare versus a standard of care, but in this specific case, he, of course, argued that this technology, because it's a different technology, may cost much more than the latest generation DS. So he would prefer to see some superiority. In a way, you have addressed that, because, of course, the study was designed to show superiority in the landmark analysis. But what do you want to reply to this legitimate concern that maybe the device is not superior and so doesn't justify cost effectiveness?
Well, the price is not established, not in my country at least, and of course it will be higher than the usual Ds that we have. I think in the beginning people will use it for special subgroups, maybe younger patients, maybe LED lesions, maybe long lesions or so on, and still continue to use the traditional ones because they are much cheaper. But as we follow these patients for at least 5 years, both in the bioadaptor RCT and in our trial, we hope that we can give you more and more evidence that this separation of the event curves will continue, and the value will be better and better with time.
Okay, thank you. Maybe now I can switch to Mathieu and ask the two questions that come from our online audience. The first one is about, which lesions can be treated, particularly how this device behaves in heavily calcified lesions in your experience.
Obviously, in the bioadaptor RCT study, severe calcification was, a contraindication for randomization. But as you saw there, a number of patients ended up in the study who had mild to moderate calcification. So I think the jury is out on the use of it in severe calcified vessels. We don't know. Of course, the return of hemodynamic modulation in those vessels might be less. We might expect less from that in the future. So we have to see and test in studies if there's a use of this novel technology in very severely calcified vessels. That would be my initial answer.
Okay, and in terms of which patients are in the two trials, would you say that this is, a standard population with enough ACS and B2C lesions as we see in practice, or it's still a low complexity population in your mind?
Well, I can answer, first of all, for the bioadaptor RCT, where I included patients, 1 in 5 had an ACT, 2 or 3, younger patients, less calcified. So I think, of course, it wasn't an all-comers, which I think the INFINITY-SWEDEHEART was more like. There were some non-STEMI patients, but no STEMI patients in the bioadaptor RCT, no left main because of the size of the stent available at that point. We couldn't use the bioadaptor in the left main. So we still don't know if all these other lesions are also well treated with the bioadaptor. But young patients, long lesions, LADs, I think we see those every day as well. And for me, they're excellent patients to include or to treat with the bioadaptor.
Perfect, John. Thanks so much. Maybe I have a final question to you and one to David, because I see in the chat that now our viewers are asking how this compare versus DCB and bioresorbable scaffolds, which are the logical leave nothing behind strategies that you would consider as a comparator. Of course, here we have seen data versus drug-eluting stents, which is the standard of care. But I will start with you, John, and ask how this compare versus DCB in your mind. Probably there are no data, but let's imagine. And I will ask to David how this compare versus bioresorbable scaffolds, because people are concerned that the problems we have seen with scaffolds may also start with unlocking with the bioadapter. Yes or no? Of course, it's your reply. So let's start with the comparison versus DCB, please, John.
Yeah, I mean, obviously, there's certainly a hype around DCB, certainly in other parts of the world, maybe Europe a little bit lagging behind. The DCB is easy to implant, easy to use. But unfortunately, yeah, we just don't have the data, the long-term follow-up data yet to suggest that it is better than a regular DES. So in my mind, we really would need more data for that. The recent publication or in the Lancet from the Chinese group showed that, it was even inferior to a DES in larger vessels. Perhaps it has a role to play in small vessels. In my practice with CTO and bifurcations, I do use it in distal CTOs in bifurcation segments. So there it has a role to play. How it compares to the bioadapter, I think future will let us assess that.
Okay, but we have seen initial data in de novo lesions with DCB, which do not look, at least with that technology, very promising at the moment. We have other trials, of course, so we'll see with other balloons. Maybe now I can ask David to comment on the potential comparison with the bioresorbable scaffolds. Should we be concerned of long-term problems that will come along the journey, or it's a different concept, a different technology, so no problems?
Yeah, so the bioresorbable scaffolds had a lot of problems initially, and they were bulky and large struts and so on. But we had our hopes in the long-term effects, but actually they have shown not to be more advantageous even beyond 3 years compared to the regular drug-eluting stents. And even vasomotion has not been restored to a great extent than the drug-eluting stents in the studies that have been done long-term. So we think that if you do a stenting of a really big plaque volume, a lot of calcium, a lot of inflammation, you may need some sort of support long-term. Otherwise, it will kind of fall into the lumen again. And the DynamX, it gives you a support, even if it has unlocked, and kind of holds up the vessel and the lumen, which an absorbable scaffold does not. So we think that this is in between. It gives you support, but it also gives you vasomotion and flexibility. That's the ideal solution.
Thank you. Maybe, Rasha, if you allow me, a very final question to Joan, because I want everyone to be happy, because they made a lot of questions. We addressed most of them, but there is a final one regarding how you assess this concept of adaptive remodeling, because it looks like magic, but there is science behind it. Can you explain briefly?
Yeah, so obviously looking at the restoration of pulsatility, etc., was performed in a subgroup analysis. It was performed in, I think, most of the Japanese patients in this study, where IVUS OCT was performed at follow-up, and it was performed stationary. And then you're able to really assess how the volume of blood flow increases during the cyclic cardiac cycle, and also how the vessel area increases. It looks like magic, but it isn't black magic. It is really you can really observe it, how due to the unlocking mechanism of the technology, you allow the vasomotion to return and the pulsatility in the vessel to get larger. So it really is something done very precisely using IVUS and OCT analysis.
Thank you. I hand over to you, Rasha. Thanks a lot.
Thank you so much. Fantastic discussion. And I would like to encourage the audience, keep your questions coming, because we still have a little bit more time for discussion after our case presentations. So Professor Santoso, please, if you could show us how you use the bioadaptive technology in your clinical practice.
I would like to begin my presentation by expressing my most sincere thanks to Elixir and to you all for having me in this very important webinar. I would like to share a few cases Okay, I'm working in the Metro Hospital. Okay, this is my first case. Very simple lesion, as you see here on the left upper panel, mid-LED stenosis, and we implanted the DynamX 3/23, got nice result, and at 1 year follow-up, of course, the result is still excellent. But what is interesting is not this one. So at 1 year, we have the opportunity to restudy the patients, and this is just to show the stationary IFUs, which demonstrates how DynamX allows for vessel pulsatility. You see here in the upper panel, increase in the diameter during the phasic cardiac cycles by 7%. In the mid portion of the bioadapter, and in the proximal portion, the difference is 12%. So this may have important implications because it may improve the distal perfusions, improve microvascular perfusions, and also improve the endothelial shear stress. And this also confirmed the results published in the Bioadaptor randomized clinical trial. The second case is an ideal indication for Bioadaptor. A young patient, 35-year-old, with 2 vessel disease, presented with angina and very strong family history. You will see here that the patient has long segmental stenosis in the LED. So after pre-dilatations, you will agree with me that a long DynamX of 32 mm was easily delivered to the vessels. And we implanted 2 overlapping bioadapters. And after post-dilatations, we got very much acceptable result. And the total length of the stent is approximately 60 mm. So we know that stenting problem of long lesions include more difficult delivery of long stent. And you see here that DynamX is very easily deliverable. And also, if we use the second generation stent, according to the Giant DS trial, there is an increasing mace rate if you use a stent longer than 40 mm. So this is an ideal case for long segmental stenting with DynamX. Next. Just to show OCT findings after pre-dilatation, you will agree with me that there is a long fibrolipid burden with very minimal calcifications and balloon-induced dissections along the course of the vessels. Next, of course, we need to do proper pre-dilatation. And this is the OCT after two overlapping bioadapters. Go back. Yeah. Go back. Very nice result. So you see here that this is a very nice result. No dissection, well opposed bioadapters and well expanded also. Nice. This is the QFR showing a subnormal QFR value of 0.32 at the baseline, and which then becomes normal at the final results. Next. This is also a good indication for DynamX diffuse small vessel disease in the LAD. And we treated this with a hybrid procedure. The distal part was treated with DCB because vessel diameter is smallest, 2 millimeter in diameter. But the more proximal part was treated with long DynamX. You'll see here also that delivery of DynamX is also very easy, and we got excellent results. This is very good indication for DynamX. Next. So we know that stenting problems in, so this is just to show the IFUS findings. You see that the results on IFUS was also excellent with DynamX. QFR was also normalized after we finished the procedure. This is the last case, a patient with triple CTO affecting the proximal right coronary artery, LAD, and also the LCX. This type of patient was excluded also in the both in the Bioadaptor randomized clinical trial and also in the INFINITY-SWEDEHEART. We know that there are many stenting problems of long CTO, more difficult delivery of long stent, extensive disease in the long stent, CTO, negative vessel remodeling, late stent malposition, suboptimal stent deployment, incomplete lesion coverage, stent fractures, restenosis, and so on. Next. And this is just to show that even very long DynamX, 2.5 by 38 and 3.0 by 38 millimeter were along the course of the vessel, and we obtained a very nice result. And this is just to show the OCT findings. Of course, we need to do proper lesion preparations next. And we got a very nice result. Well expanded, well opposed DynamX, no edge dissection. And QFR was normalized back to normal 1. And this is just to show how we treat the CTO and the LAD and then LCX. Excellent result with also very long DynamX. And this is at 7-month follow-up. Restenosis. And QFR was also in all 3 vessels. I just want to show the OCT findings in the right coronary artery because of time limitations. But you'll see here that in the right coronary artery, the DynamX were nicely covered with thin endothelial layer, no neointimal hyperplasia or neoarteriosclerosis, and no fractures. I think it is fair to conclude. Next. The DynamX has the ability to adapt vessel physiology, already mentioned, and hence the use of Bioadaptor in broad range of lesions, including complex anatomies, has the potential to improve outcomes. Implantation technique tips and pitfalls are similar to best-in-class DES. So in my single center experience, Bioadaptor in complex PCI is illustrated in these cases is very much encouraging and probably better than expected. Thank you so much.
Thank you so much. That excellent presentation. So it would be great if we could just actually sort of ask you some questions. Davide, do we have any questions in the chat?
Yes, actually, there are other questions. One, it's interesting. I'm very curious about the reply. Does anyone see a utility for these stent technologies in myocardial bridges?
I incline not to use Bioadaptor in myocardial bridges because we have no data, no long-term data whether this is a good strategy. But we also know that this is inherited. So usually myocardial bridging is not associated with significant ischemia unless if it is complicated with atherosclerosis and stenosis. So in my experience, I have no single case with myocardial bridging which has DynamX implanted.
Yeah, thank you. And another question to you. Surely you had cases of calcification, obviously. So the audience wants to know from you as a heavy user whether you feel that this is a technology that can be adapted to heavily calcified lesions or should be not used.
Yes, I must admit that I have no limitations in implanting DynamX in my series. We also know that in the bioadapter randomized clinical study, approximately 20% of the cases has moderate to severe calcifications. Important strategy here is that to lesion preparation. So we always use intravascular imaging. If the calcium volume index is more than 3 or 4, then we have to use either atherectomy procedures or IVL if we have that facility for good lesion preparations. And we also need to have calcium cracks. So that means that if we have good lesion preparations, then we will also have a good long-term outcome. So we have plenty of patients with calcifications, and so far the result is encouraging. Of course, I didn't involve in the randomized clinical study, but so far the result is encouraging.
Thank you. And maybe Rasha, one final question to Johan, actually, because it relates to the Bioadaptor RCT trial. So they want to know whether over 2 years there are data about late acquired malapposition, and if so, how can we handle this, let's say, complication?
So, so in the Bioadaptor RCT, there was in a control arm, in a subgroup, there was a control angiogram of imaging at 1 year. But at 2 year, there's no data on that yet. So I can't really comment on the presence of late acquired malapposition at 2 years. That's something we don't know.
Okay, Rasha.
Thank you so much. So that was a fantastic conversation, fantastic data that we were shown, and also it was so good to see the clinical experience and exactly what it's like to use this technology. I think we have some kind of key closing remarks, but hopefully with you at home and your interaction, you've really guided the chat around this webinar. But just a few things to kind of highlight. So we have seen today some of the real promise around the DynamX Bioadaptor platform. It's a novel approach to coronary angioplasty. It gives us a technology with a design and a mechanism of action that's aimed at really addressing that unmet need that we have in terms of residual event rates with the current technologies of around 2 to 3% per year. And importantly, it seems to have its main promise once it uncages and later on as we see vessel motion restored. Importantly, we think that this might make a real difference in terms of outcomes for patients who have known atherosclerotic disease and obviously a high risk of recurring events and ongoing issues. The other thing that I guess is important to think about is that there seems to be a kind of sustained benefit because of, as David talked to us about, that concept that it's somewhere in between the whole leaving nothing behind technology and our conventional drug-eluting stents. We've seen the 1 year outcomes for INFINITY-SWEDEHEART, over 2,400 patients that really supported the effectiveness of this platform in treating coronary artery disease across a very broad patient population, and I'm sure we're going to see lots more data come out. And we've obviously also seen the data from the Bioadaptor RCT. So it's really been a fantastic conversation today. Thank you all for being so engaged at home and really involving us all in your conversation. Thank you for asking questions. Thank you very much to our colleagues who presented data today. Thank you, David. Thank you, Johan. Thank you, Professor Santoso. And thank you, Davide, for being my co-moderator and really leading the conversation. I'm sure there's lots more data to come and there's lots more conversations we can have. So thank you very much.